Hello, everybody. Welcome to part 5 of Introduction to Dermoscopy in General Practice. My name is Dr. Kwesi Appiah. I'm a GP with extended role in dermatology. If you've been following my previous YouTube videos, this will be the 5th session of what we have been doing on Introduction to Dermoscopy. So we'll take up from where we left off, and we will turn to part 5 of our introduction to dermoscopy. So we have been doing two-step algorithm in the last couple of videos. The first one we did is the first step. We're still on the first step. We've done the differential and diagnostic criteria for melanocytic lesions on dermoscopy. We've done the diagnostic criteria for seborrheic keratosis on dermoscopy, and we've also done the diagnosis criteria of BCCs on dermoscopy. So what we're going to do this time, and also we did the diagnostic criteria of vascular lesions on dermoscopy. So in what will happen in the next video, we're going to look at the second step of diagnostic criteria, where you have established from your first step that the lesion that you are seeing has all the diagnostic criteria of a melanocytic lesion, and therefore you go on to the second step. So in the second step, you are using standardized algorithms for dermoscopic assessment for specifically melanocytic lesions. And there are various algorithms or various steps in the second steps tools that you can use. You have the modified pattern analysis, which is what we're going to use in this series, in this video. What we're not going to delve in is the ABCD rule, the Menzies rules, the 7 points checklist, and there are various others that has been published, which you can see on various websites on dermoscopy, and it depends on which one you favors. You can stick to them, but we're going to concentrate on modified pattern analysis, and in this, which has a sensitivity of 83% and specificity of about 83% as well. So it's pretty good in terms of the methodology that we're going to use here in distinguishing between melanocytic lesion, like benign melanocytic lesion, and a melanoma. That's what the second step is about. So in pattern analysis, there is your pattern analysis evaluates the global patterns of the lesion as well as the local features of the lesion. So if it's a benign melanocytic lesion, it tends to demonstrate a symmetrical concentric distribution of all the dermoscopic structures and colors which are pathognomic, or which are characteristics of a melanocytic lesion. Okay, if it is not regular, then it means that it is a melanoma in terms of color and pattern. So the global patterns of melanocytic lesions include the reticular pattern or diffuse patchy network, or the globular pattern, which is also known as a cobblestone appearance, or globules of shades of brown of how the lesion looks under dermoscopy. Think about this. Always remember, we are only talking about melanocytic lesions, okay? You have established that what you're looking is a melanocytic lesion. Now you're going to establish whether it is a melanoma or another type of melanocytic lesion, such as the starburst pattern, which is kind of specific for the Spitz nevus, as well as the homogeneous pattern analysis, which could be for blue nevus in terms of homogeneity. Okay, and then again the parallel pattern, which is kind of along the varus palms of the soles of the feet only, which is a pathognomical for, or kind of, which is characteristics of benign melanocytic lesions in the acral surfaces. Whenever you see a global pattern which is multi-component, which is combination of reticular, globular, starburst, homogeneity, and parallel, in all those kind of multi-component pattern, and usually not concentric, you will some of them can give you a kind of a regular pattern in a multi-component sense, but sometimes you might have an unspecified pattern when you worry about a melanoma. So the basic colors of melanocytic lesions consist of black, brown, and blue colors. Although, of course, there are exceptions such as amelanocytic melanoma, which we will see. So this is the global pattern: reticular, globular, homogeneous, parallel, and then the starburst pattern, which I described extensively in my previous talk on similar to what you find in Spitz nevus, or you might have a multi-component pattern which has got a bit of homogeneity, a reticular pattern and globular pattern as part of the component of the lesion. Then really the unspecified structureless white, blue figures that always raises the eyebrow and suspicion of melanoma. So if a melanocytic lesion is composed of two patterns, then the dominant pattern should be used. So you might have a acquired melanocytic nevus, which will have a peripheral pigment network and a central dot globules or with a peripheral dot globules with a central homogeneous pigment. These nevus you call them either reticular globular or globular homogeneous pattern respectively. Okay. A single pattern with concentric color distribution most likely correspond to a benign melanocytic lesion. So you have a single pattern with a bit of concentric distribution. Think about benign melanocytic lesion. If a lesion with the multi-component pattern has three or more structures, then you will worry about you worry about something sinister. So multi-component pattern with irregular distribution of the colors or structures, really think of a melanoma, a malignant melanoma. Okay, that is a global pattern. If you cannot specify what kind of pattern you're seeing, it's a variety of lesions, and it's very not clear. Non-melanomacytic lesion. If it's featureless, think of melanoma. Okay, that's global pattern. So a couple of dermoscopic images of global pattern. This is a reticular patterns, a global features. You see this is network, generally reticular pattern. There's a globular pattern, which is the dots or globules. So you can see that is well regularly and distributed in there. And then you have the starburst pattern here. And also you have this homogeneous pattern in this place. It's just regular brown homogeneity in that sense. Mostly you find that in Dermo nevus, the previous lesion. There you might have a multi-component that has quite a bit of a pigment network and also a globular pattern or homogeneous pattern, brown pattern in the middle there. It can get this in a compound nevus or even in a benign congenital melanocytic nevus, but it's mostly in compound nevus, like a fried egg appearance, like what you can see. You can see a fried egg appearance in there with the homogeneous middle and the network on the edges. And then parallel patterns is what you find in mainly acral surfaces, which we'll come to specifically. Another multi-component pattern, however, this multi-component pattern is not regular. It's you've got the streaks at the edges here. You've got the globules there. You've got some blue-white structures there. You've got some scales, some white areas of regression here. We also got some streaks there and active growth of globules at the edges there. Very, very irregular, atypical distribution melanoma. Okay, you worry about this, you refer to weak weight. Parallel pattern, this is regular parallel patterns in the lattice and distribution. This is on the palmar aspect or the sole of the feet. This is also parallel pattern. So this is another global pattern you can describe. So after the global features, then you look at the local features, and the local features, you can be either the network features, so pigments network. Then you are looking at, is the network features typical where you have light to dark brown in color, regular, delicate network, usually thin at the peripheries, okay? Or is it an atypical network where you have black, brown, gray, dark brown in different colors, or irregular and thick network ends abruptly at the periphery and things like that. So this is atypical pigment network. These are local features of the pigment network. So, you know, other authors think about networks where the lines are thicker and the holes are being particularly indicative of atypical network, as we mentioned about. So yes, so it's not just network, the pigment distribution, but also the thickness of the holes as well. So you remember this image we've seen before, local features, and clearly demonstrated here with the atypical, that it's like this is the typical network on the peripheries. This is a local feature because you're looking at the periphery of this melanocytic lesion, and that's a typical network. And it's a compound, probably a compound nevus, because it's got two reticular surface, and it might have more globules at the end. Whereas in this atypical network, there is no there is kind of atypical distribution of the pigments in the network and the color. Again, very, very highly indicative of a melanoma. Okay, so these things, melanoma, even with other blue-white structures in this here, but this is atypical pigments network, irregular holes, irregular and networks, irregular color. That's a melanoma. When you're looking at a pigment network, this is a scanning electron microscopy of the epidermal retiridges, looking up from the dermal side of the skin, and so you're looking at the holes there, which should be regular in this lesion, and that's what you're looking at. And so it shows the relationship between the actual epidermal shape and the pigment network that you see on dermoscopy. So this is how it looks like histologically, or looking at electron microscopy from scanning electron microscopy from neither surface. Typical network will correspond to usually the basal melanosis, where atypical network will indicate kind of a thicker distribution of the melanin in the epidermal epidermis up to the horny layer. So because of the atypical network, as they come up from the epidermis, from the basal layer coming up, then they start getting darker, hence they appear much more darker, and they are more due to the distribution of the melanin in the epidermis. Okay, hence the dark, thick pigments network. So other local features that you see are the dots and the globules, okay? And you have to assess within the local features, are these and dots and the globules, are their distributions, are they defined, well distributed? So they will be round, oval, various sizes of brown, black or blue structures, but are they well distributed? Are they irregular distributed or regular distributed? That's what you're looking for in terms of the local features. So dotted globules are divided into regular and irregular. So brown globules often are observed in benign moles, whereas when you see black dots tend to be seen in melanomas. Okay, so you're really looking at these dots, globules in the local features, whether they are indicative of melanoma or benign melanocytic nevus. Remember, we're looking at distinguishing between melanomas and benign melanocytic nevus in this pattern analysis in the second step. Regular dots are distributed evenly and in the entire lesion, or in a concentric pattern. So either localized in the middle or in the peripheries, really in a concentric pattern. Okay, so that's what. By irregular dots, if observing part of the lesion in the peripheries of the or the peripheries of this, you have to think about this is a melanoma. Okay, particularly at the peripheries. So local features, dots and globules, and you have here this regular globules here, there are some, there are two on even sides. They don't all have to be even sides, but so far as they are evenly distributed, large ones and small ones regularly in there, that is benign. When they are irregularly distributed, are the dots and globules at the edge of the lesion, at the peripheries of the lesions, you are worried about something else. Irregularly distributed, and other features as well as scarring, regression. Always keep on banking on that scarring, regression. When you see that in the white areas, bluish areas, this is a melanoma. So it's not the only feature you're looking for, but the other things add to your armory to confidence of diagnosis. Streaks assess the streaks to determine whether they are regular or irregular. So streaks, as I said, are defined as linear structures of either brown, black, or blue-gray colors at the periphery. And histologically, there will be kind of adjacent nets of melanocytic cells and usually circumferentially arranged to create a starburst pattern, which is a hallmark of a Spitz nevus or Reed nevus. Because Spitz nevus in children, as I said, don't have streaks, they don't have a starburst appearance. But Reeds of nevus or Reed nevus show this starburst appearance typical of streaks. If it's irregular streaks, as I demonstrated in some of the other melanomas, then it will be confined to part of the lesion and show color and shape of variegation. So different colors, dark, brown, and when you see irregular streaks, you think of melanoma. Okay, so local features here. This is a starburst, Spitz nevus, which has got regular streaks all over. It's like a star or protruding towards the edges. And this is a Spitz nevus. And whereas in the thick melanoma, you will have these streaks at various different peripheries there. And then again, all other features is added to it to allow you to have confidence that it's a melanoma. But, it tells you that it's there in a melanoma. And then the other local features you're looking for is blue-white regression structures. Assess for the presence of blue-white veil and regression structures. Blue-white veil is defined as irregular diffuse blue-gray to whitish blue pigment if in a raised area of the lesion. Regression, on the other hand, is a white area, which is usually scar-like area, or blue area, which is blue-gray appearance, or peppery or multiple blue-gray dots, which corresponds to fibrosis or melanophages, and also flat in areas of the lesion. So regressions are usually flat. Blue-white veil are usually thick in the lesion. Okay, all these are features of suspicious lesion. Remember that we did mention in one of my videos about blue-gray areas or blue-gray structures can also be seen in BCCs, but they are quite different from melanomas in that the lesion would have initially demonstrated features suggestive of melanocytic lesion, which will help you to know that it's a melanoma or a BCC. Sometimes biopsy is what's going to show you, so histology. Anyway, when you see blue, gray, white, it needs to cut out. If you're not sure it's a BCC, 2-week wait, no one will criticize you on that. The two structures, these two structures often concurrently observed in the lesion and substantially mean that the lesion was most likely a melanoma, as I said. So blue-white structures in a single term, and this is what I said earlier on, considered blue-white structures in 3 points checklist, but it's different, but then still you're going to refer anyway when you see such a thing in your lesion. Okay, the blue-gray structures are usually smaller, more arranged radially and compared to blue-white veil in melanomas. That's just a small point to distinguish whether you're looking at for a BCC or just a blue-white veil or blue-gray structure found in BCC. Yeah. Blue-white veil, again, this is a schematic diagram of how you see there. And then you've got the regression structures, the white area here in that sense. Okay, that was the short part of it, but thank you for listening to this video, and we will surely you can click on the next video for introduction to Dermoscopy part 6, and I'll see you soon.